Puri sir, can we start the session? Can you please unmute? Ma'am, we'll just wait for 2 minutes.
Absolutely.
Yes, sir. Good afternoon. Sir, we'll just start. Kiran sir, can we start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the national guidelines for HIV care and treatment 2021. Today's topic is HIV and OI's respiratory system, and the speakers are Dr. A.K. Puri sir from NACO, Dr. Upasna Agarwal ma'am from NITRD, and Dr. Reshu Agarwal ma'am from CDC India. We welcome you all to today's session. Participants are requested to kindly put their questions in the chat box. We can take them up at the end of the session. Kiran sir, now I request Puri sir for the opening remarks, please.
So I welcome all. This is a very important session. All the participants from all the ART centers, Dr. Upasna Agarwal, who is looking after NITRD, which is a very important center. She's running both HIV and TB over there. How to manage how to prevent TB amongst the HIV. That is, if you want to see that, for that you have to go visit NITRD. Queue management and everything, it's so good over there. I also welcome Dr. Reshu Agarwal. And this session is why this is important is because TB is one of the most common opportunistic infection amongst the PLHIV, and not only TB but other respiratory diseases are also equally important, and we can prevent these if we are taking care of the PLHIV in time. If timely chemoprophylaxis is given, if timely action is taken, if timely, the investigations are done, then these things can be preventable. Cotrimoxazole and other prophylactic things, if taken care of, then we can definitely prevent TB and other infections of this respiratory. And now I invite Dr. Upasna Agarwal and Dr. Reshu for further opening the further session.
Thank you, sir. Sir, thank you very much, and thank you always for your kind words and your appreciation. Before I begin my talk, can I request Dr. Reshu for her opening remarks, for her comments? Because Dr. Reshu is a faculty today, but mostly the talk would be covered by me, so I would request her to give some remarks.
Thank you so much, Dr. Puri and Dr. Upasna. And I think that today's topic is really very important, especially the respiratory OIs, because at the ART centers, we still find people coming in late stages and they are still symptomatic. So this piece is really very critical. And especially, I think when we talk about respiratory OIs, TB and PCP are two crucial OIs which we need to focus on. So for the TB, I think we really had a very detailed talk 2 weeks back where all aspects of TB were discussed. So for today's session, I think we can skip those slides and instead of repeating everything, and we'll be happy to take any questions on the TB part later on. So over from my side, and I'm there to support with any aspects of the respiratory OIs today. Thank you.
Thank you so much, Dr. Reshu. So with this, I would like to begin my talk and welcome again all the ART centers.
Ma'am, sorry to bother you. Ma'am, can we do the pre-test?
I'm so sorry.
It will be good.
Very sorry, please let's go ahead with a quick pretest. And
Thank you.
while they are putting up the pretest poll, I would like to welcome all the ART centers. We met last month with an exhaustive talk on HIV TB. And I hope we were able to clear some of the concepts.
The pretest is now available on your screen. So there are 3 questions in all. Please scroll through the questions and answer all the 3 questions. Participants are requested to please read all the 3 questions and answer them.
I think, Shweta, this is sufficient time for a pretest. Or what do you think? You want some more?
Yeah, ma'am. We usually give a minute for a question.
Acha, per question. Okay.
Ji. Kiran sir, we can end the e-poll now. Thank you to all the participants for attempting the pre-post. Please note your attendance is recorded with the post-test. So please remain with us for the post-test also. Ma'am, you can continue, please.
Okay. Thank you so much. So once you pull down the pre-poll, I'll move the slides.
Ma'am, you can just click on that cross.
Okay.
Yeah.
Actually, my because of screen sharing.
Yeah, the next slide is visible.
So can you see the?
Yes, we can see the slide, ma'am. The pre-poster is not visible.
Okay, but how do I?
You can just click on that cross, ma'am, at the top.
It's coming under screen sharing actually.
Okay, maybe you can stop sharing and then share again.
And then do it again.
Yeah.
Okay. Is my
yes, ma'am. It's visible, ma'am. Yes.
So good afternoon, everyone. So beginning the talk once again, as everybody has already reiterated, it's a very important aspect to know about the respiratory OIs, because as a system, as a body system, it is a very susceptible system. It is susceptible to pollutions, it is susceptible to airborne infections, which are a very common thing when you look at the way our country is made and the way we are populated. So it is a very, very important system for catching infections. And today we will talk about the national guidelines for management of respiratory OIs. Coming to the first slide, we would be covering the introduction and the scope. We will talk a very little bit about MTB because we have already talked about it in great detail. We will talk about PCP, bacterial pneumonias, MAC, that is Mycobacterium avium complex, Talaromycosis, which was previously known as penicillosis, and other pathogens with pulmonary manifestations. Well, as an introduction, preventable and treatable respiratory infections are seen in up to 2/3 of all PLHIV. And here we have to understand the part of preventable. Prevention is always better than cure. And if we can prevent, then why need to treat after the patient becomes morbid and gets all that side effects of drugs? So preventable and treatable are there. Frequent respiratory complaints in people living with HIV is cough, dyspnea, a pleuritic chest pain, which could be either alone, any one of these, or if they could be in combination. HIV-associated respiratory diseases are like upper respiratory infections, sinusitis, bronchitis, and the pneumonias, which are mostly bacterial pneumonias. Now, if we look the importance of, just a minute, I think this is covering the, my screen actually is covering the, I'm sorry, give me 1 minute, please.
Ma'am, try pressing escape.
Yeah, that is what I'm trying to do again. Sorry, I actually stopped sharing. It is covering the top part of my presentation. So I don't have access to those slides. Is there any way to unfreeze the top?
Kiran, can you please help?
Just click on the
More?
Minimize, maximize button, ma'am. The middle one, the square one.
Okay, the square one, the
on
new
that
share.
panel.
New share just click कर.
नहीं.
देखिए इस पे एक म्यूट है, start video, security, participants, chat, polls, new share, pause share, annotate, slide control apps.
No, nothing of that, ma'am.
अच्छा चलो, then let's continue. No problem, then let's continue.
Okay.
Is it possible for you to share the screen?
I can do that, ma'am.
That would be better because if I can't see half of my slide, then
G.
Yeah. So I'll stop sharing.
Right.
I apologize to the audience for the slide glitch. Actually, when we use technology, so sometimes these things happen. Yeah, this is better. So next slide, please. So now this basically shows the association of pulmonary infections with CD4 counts in PLHIV. And though these are a guide to possibly saying that which infection is affecting the patient currently, these are not sacrosanct. Like for example, Mycobacterium tuberculosis, we all know that tuberculosis can occur at any CD4 count. It also occurs in people without HIV who have an absolutely normal CD4 count, but it is common with CD4s of around 400, 500. Bacterial pneumonias are more frequent or recurrent when the CD4 falls less than 250. Suppurative lung diseases and sinus diseases when CD4 is less than 100. PCP definitely when CD4 is less than 200. MAC when CD4 is less than 100. And cytomegalovirus respiratory illnesses when CD4 is less than 100. So one point that we must all understand is that if there is a patient who comes with a CD4 less than 100, then he can have any of the above. He can have either TB, pneumonia, PCP, Mycobacterium complex, or cytomegalo. But yes, if there is a patient with a CD4 of 400 or 500, or maybe even 350, and he has respiratory symptoms, then I would automatically not think of probably PCP and Mycobacterium avium complex. I would think more in terms of Mycobacterium tuberculosis or a community-acquired pneumonia. So that is the importance of knowing at which level we should expect of CD4, we should expect a respiratory infection. Next, please. Next, please. Next. So we have already covered MTB in great detail in the previous section. The only thing that I want to highlight in this slide is that extrapulmonary manifestations are more common in people living with HIV. But having said that, pulmonary tuberculosis is not less common. But still, the most common component of TB would be pulmonary TB. Next, please. This slide is basically showing that the risk of developing TB for people with HIV who have latent TB infection is 16 to 21 times higher than people who do not have HIV. And currently we have about 71,000 people living with HIV who also have active tuberculosis. Next, please. So next, this is this we had already discussed how each disease affects the other. Next. And now I think we would have to, okay, so let's go to this. What would be the features of pulmonary TB if HIV disease is still early, like there isn't any marked immunosuppression? So then everything in TB would be as we see in non-HIV people, like it would be post-primary TB. There would be cavitatory disease in the upper lobes and the smear would be positive. Now, but if it is advanced immune suppression, then the clinical presentation and the X-ray can very much resemble primary TB with atypical presentations like infiltrates in mid to lower zone, intrathoracic lymph nodes, infrequent cavities, and sputum may be negative. But again, having said that, we see all kinds of TB in all kinds of immunosuppression with people living with HIV. Very low CD4s also have positive sputums and have cavities, while PLHIV with slightly higher CD4 counts also have atypical features like infiltrates in the lower lung lesions. So these are just things that you need to keep in mind, though they are not absolutely compartmentalized that this is how early HIV TB will present and this is how late HIV TB will present. Next, please. I think we can skip the next few slides and go directly to the slide before PCP. We have discussed all of this in our previous talk, and it would be counterproductive to talk about it again. We have talked about 4S screening. We have talked about intensified case finding through CBNAT. We have talked about how we have to manage TB under the national program. We have to follow the DOTS. We have to follow the NTEP guidelines. We have actually covered everything about TB. We have also covered about the prevention of TB and how we can have infection control in ART centers. All these things have been covered in great detail in previous talks. Next, please. So now coming to PCP, which is actually called Pneumocystis jirovecii pneumonia. So it is also written as PJP in many textbooks. Earlier, the name was Pneumocystis carinii pneumonia, and so some people retain the acronym of PCP. Next. Well, PCP is caused by a ubiquitous fungus. By ubiquitous, you mean a fungus which is available all around in the environment. It would be in the soil, it would be in the air, it would be in the water, and it is available almost everywhere. And the name of the fungus is Pneumocystis jirovecii. The point is that the fungus is there in the environment, but we never get pathological disease because of this fungus because people have an immunity against these low virulence fungus. But when the immunity falls, as in the case of a PLHIV, even a low virulence fungus like PCP can cause a disease. Hence an opportunistic infection, and hence more common in patients with HIV, but you also see in patients of cancer who are on chemotherapy and who are immunosuppressed. So it's a ubiquitous fungus causing a pneumonia in people living with HIV. Use of ART and prophylaxis for PCP have dramatically reduced the number of new cases of PCP. Now, this is a table which basically shows it occurs in people who have PLHIV who have AIDS. In those cases, nearly 20 to 30% people can have PCP, and it is associated with a mortality even after treatment. It usually occurs when the CD4 count is less than 200, and healthy children have antibodies to Pneumocystis jirovecii by 2 to 4 years of age. As I said, that it is a ubiquitous fungus. So if a child is healthy, then by constant environmental exposure of a Pneumocystis fungus, he would already have antibodies. Next, please. So what are the clinical manifestations of PCP? Dyspnea is the main symptom. This is the key presenting feature of PCP. Initially, it occurs only on exertion, but later at rest also. Low blood oxygen levels, that is hypoxemia, can be confirmed, is also present, and it can be done with the pulse oximeter. And a rapid respiratory rate is also seen in some cases for PCP, but sometimes a rapid respiratory rate is able to compensate for hypoxemia. So what would happen? The patient is actually having hypoxemia, but the patient, by increasing his respiratory rate, is able to maintain an oxygen saturation. So whenever we are looking at oxygen saturation, this is a lesson that we learned in COVID also. Please also keep an eye on the respiratory rate. It is possible that the patient might be breathing more than 24 times a minute or around 30 times a minute and then compensating his oxygen saturation. But we have to understand that the disease is still severe. A dry cough, tachypnea, temperature is usually normal, and chest X-ray characteristically shows a ground glass appearance. A ground glass appearance means a hazy appearance, that it looks as if you have taken glass and thrown it over the X-ray. So there's a ground glass appearance, which is more pronounced in the lower lung zones. Usually intrathoracic lymph nodes are not a radiological feature of PCP pneumonia. Now with this clinical features, next please. The one thing that I really want to emphasize here is disproportionate hypoxemia. Disproportionate hypoxemia is the sine qua non of PCP. You would have a patient, he would come to you saying, I'm not feeling well. I have this dry sort of cough, which has been there for the past weeks or few days. And progressively, I have started becoming breathless. When you look at the X-ray might appear normal, or you might find very little findings, but the hypoxemia is disproportionate. The dyspnea is disproportionate. The increased respiratory rate is disproportionate to the radiological manifestation. He is a HIV positive patient. His CD4 is hovering around 200, and you have your diagnosis of PCP. So this is usually how an adult with PCP would present: a dry cough with progressive dyspnea, X-ray almost normal, CD4 around 200 or less than 200. Now, how does it manifest in children? In children, it would manifest as tachypnea. Now, for children, we have to understand what is tachypnea, because children usually have a higher respiratory rate than adults. For an infant who is less than 2 months of age, you could say a newborn, would have if the rate is more than 60 per minute, up to 60 per minute, respiratory rate would be normal for an infant who is 2 months of age. For somebody who is between the age of 2 months to 12 months, that is 2 months to 1 year of child, 50 per minute is normal, more than 50 per minute is tachypnea. For a child between 1 to 5 years, 40 per minute is normal. And for a child more than 5 years, 30 per minute is normal. So if you exceed 60, 50, 40, 30, according to the age of 2 months, 12 months, 5 years, and more than 5 years, that is when you call tachypnea in children. The reason I'm emphasizing on this so much is because many ART centers have people who are used to looking after adults. And when it comes to CLHIV, they sometimes become confused. So having an increased breath rate, having shortness of breath, cyanosis, or a sudden onset of fever, with a non-specific chest auscultation, like chest is absolutely normal, or in the adults, you might find few isolated inspiratory threats. And when you look at the chest X-ray, it is either normal or there is a ground glass appearance. When we have to understand that in children, the parenchymal infiltrates that we would see will be first in the perihylum region, which would then gradually reach the apical portion. But these are always not seen. It is very, very difficult to pick up an X-ray of PCP if you do not have a high index of suspicion. So high index of suspicion comes from your clinical findings. You see that the patient is dyspneic, his chest is clear, X-ray is not showing anything, CD4 is low. So keep a high index of suspicion if you want to pick up PCP. Next, please. So as I just said, clinical presentation, blood tests, and nothing is pathognomic. There is nothing which you can say, this is the one thing that you get, so you can diagnose it as PCP. Like for TB, we say, okay, you get an AFB in the smear, it is a confirmed TB. You get a CBNAT MTB, you get culture MTB, it is confirmed TB. It is nothing else. But there is no such thing that is available for PCP for the simple reason it is very difficult to isolate the PCP organism. The number one problem is that there is hardly any sputum in patients who develop PCP. It's mostly a dry cough. Now, if you do a saline nebulization and try to get out some sputum, then also it is almost very difficult to get any sputum in a PCP case, even with nebulization. That is what we have seen. So the best test for picking up a PCP is through the BAL. Now, getting somebody to put in a bronchoscope in a HIV positive patient suspected of PCP, then putting in some saline and doing a bronchoalveolar lavage, then sending that lavage, because this is a time sensitive test, the Gomery test or the silver methionine test. These are very, PCP tests are time sensitive. You have to then send them to the lab. The stain has to be freshly prepared, and then it has to be put up for stain, and then PCP can be definitely diagnosed. So this is actually mostly outside the purview of a ART center OPD practice. Next. So mostly the diagnosis of PCP remains presumptive. It would be the presence of clinical symptoms, low CD4 count, presence of oral candidiasis, basically showing that there is a stage 4 disease, suboptimal prophylaxis in the past, an oxygen saturation which is low and which would also indicate the severity, a ground glass appearance on X-ray. These would be how you would presumptively diagnose a patient of PCP. And if you have access to an LDH level and you suspect the patient of having PCP, just look at the LDH. And high LDH means an unfavorable sign. We saw that in COVID also. It is basically a manifestation. It is basically a inflammatory marker in such cases. Next. For a definitive diagnosis of any disease, you need to demonstrate the organism. If you are able to, by sputum, actually we are not very, though the textbook sensitivity is 50 to 80%, we are usually not able to get a good sample. By BAL, it would be 86 to 97%. And sometimes you can also do a transbronchial lung biopsy, which is very, very sensitive. Actually, if you get somebody to do a bronchoscopy, if you, in a person living with HIV, please tell them to also take a small transbronchial lung biopsy. That is very, very sensitive for PCP. PCR is also a good method. For PCR, what you do is the BAL is sent for a respiratory panel in some private hospitals. And in that respiratory panel, you get a PCR for PCP. Now that is actually quite diagnostic, but that PCR has to be done on the BAL sample. So then again comes the practical problem. Next, please. Sputum is difficult to obtain. You can try hypertonic salines and liquidation. And it is even more difficult in children. Next slide. So this is the problem of diagnosing PCP. Now coming to how to prevent before we talk of treatment. So one would be primary prophylaxis. Primary prophylaxis means preventing before the disease has occurred. So for those patients who have no signs of symptoms of PCP, but they have CD4 counts less than 350, or they have a WHO clinical stage 3 and 4. In such cases, we would give a primary prophylaxis because these people are at a higher risk of developing PCP. The second would be secondary prophylaxis. Now, secondary prophylaxis is something that you give when the patient has already contracted a disease, you have treated the disease, and now you give some treatment so that the patient does not have a recurrence or a relapse. So that occurs for all patients who have completed successful treatment for PCP until their CD4 becomes more than 350. And what is the PCP? What is the prophylaxis? The prophylaxis is simply 1 tablet of cotrimoxazole double strength each day, given for the duration that we need to give. If the patient is allergic to cotrimoxazole, then we can try cotrimoxazole desensitization. Or in severe cases, we can give Dapsone 100 milligram per day for the durations for which we need to give the prophylaxis. We can only discontinue PCP prophylaxis, primary or secondary, when the CD4 count is more than 350 cells on 2 different occasions 6 months apart with an ascending trend. And the patient does not have any WHO clinical stage 3 or 4. So you have a patient, you have put him on PCP prophylaxis, either primary or secondary. you get a CD4 done after 6 months, you get something that is more than 350. That is not the time to stop. You have to wait another 6 months, get another CD4, and this time also the CD4 should be more than 350 and it should be more than the CD4 that was there in the previous 6 months. Like if the first 6 months was 350, then the second one has to be something like 400, 450, 500. You cannot have 350 and then you have 325 and you say, or you cannot have 375 on the first 6 months and then you say, okay, it is 350 in the second 6 months and now I will stop it. No, it has to be an ascending trend, and the patient should not have any age-defining illness and no other stage 3 illness. Next, please. I think this we have already discussed, that we give cotrimazole primary. I think we just discussed this. So as far as the timing of cotrimazole, if the patient has TB, that is a stage 3 or stage 4 disease, we know we can start as soon as TB is diagnosed, we can start CPT, and along with ATT, we can start CPT. And once the patient is comfortable with ATT and CPT, that is when we start ART. But otherwise, this scenario of timing has slightly changed, because now we are giving ART to everybody, irrespective of CD4 count, and we are doing the early initiation of ART. So sometimes we give a sample for CD4 in our ART centers, and we do not have access to the ART, to the CD4 counts. Prior to that, the ART gets started. So in case you do not have a CD4 count, you would obviously have to, and the patient does not have a stage 3 or 4 disease, your timing of cotrimazole will be driven by your CD4 count availability. Next, please. Secondary, as we said, that as soon as you complete the 21 days treatment for PCP, after that you would continue to give secondary prophylaxis. Dosage is 1 tablet of double strength. Next, please. Now for pregnant and breastfeeding women. Women who fulfill the criteria for CPT prophylaxis should continue it throughout pregnancy. No need to stop if the patient gets pregnant. And even if for 6 months and throughout pregnancy, you should continue CPT. Like during pregnancy is no time to stop CPT prophylaxis. If a woman requires CPT during pregnancy, it should be started immediately, regardless of which stage of pregnancy she is in. Breastfeeding women can safely continue CPT when indicated. Allergic to sulfa would be 100 milligram dapsone or desensitization to cotrimazole. Next. There's no specific laboratory monitoring that is required for cotrimazole preventive therapy, and discontinuation we have already discussed. Next. So now how do you desensitize cotrimazole? Now somebody who is sensitive to sulfa drugs and gets a mild, like a skin rash or neutropenia or fever with cotrimazole, it is actually worthwhile to desensitize them, because cotrimazole has a very wide spectrum. Not only does it prevent PCP, it also prevents malaria, it prevents bacterial pneumonias, it prevents some diarrheas, it prevents toxoplasma. So it is really, really worthwhile to desensitize the patient to cotrimazole instead of shifting directly to dapsone in case the reactions were not very severe. Dapsone should be kept for very severe reactions to cotrimazole, where we cannot take a risk of desensitization. So for desensitization, usually we ask the patient, or we arrange for that cotrimazole syrup. First day you give the patient 2 ml. If the patient tolerates that, second day you give him 4 ml. If tolerated, third day 6 ml. If tolerated, fourth day 8 ml. Fifth day again 8 ml. And now if the patient has tolerated all of this, then you can go on to the full dose of CPT. And most likely the patient would be able to tolerate it. If not, then obviously stop again and shift to dapsone. Next, please. Now, what are we have already discussed CPT indications in adults. In children, it is slightly more. So we have to understand that for all HIV exposed infants from 6 weeks of age, or if they are actually, if it's a hospital delivery and they are HIV exposed, by HIV exposed, we would mean that they are born to a HIV positive mother. irrespective of the ART status, whether she was on ART or she wasn't on ART, then as soon as the child is 6 weeks old, please start giving the patient CPT. When at 18 months, HIV infection can be reliably excluded. If the child comes out to be HIV negative, we can stop the CPT. If the child turns out to be HIV positive, we continue the CPT till 5 years of age. So all HIV infected infants and children, see, look at the terminology. First it was exposed and now it is infected. So all HIV infected infants up to 5 years of age will receive CPT regardless of the WHO stage and regardless of the CD4 count. Once the child crosses 5 years of age, then the decision to continue would depend upon if clinical or immunological indicators confirm restoration of immune system for more than 6 months, which would again mean that a child more than 5 years of age with WHO HIV disease stage 1 or 2 or a CD4 count of more than 350 cells on 2 separate occasions, not less than 6 months apart, that is when you can stop CPT in a child more than 5 years. And if a CLHIV at any time during his childhood, again if he develops a CD4 less than 350, again if he develops a stage 3 or stage 4 disease, again the patient will be started, the CLHIV will be started on CPT. Next. So for all children more than 5 years, it remains same as adults. For secondary prophylaxis, it remains same as adults. Next, please. So this is the dosage chart for children and it is according to the weight, less than 5 kg, 5 to 10, 10 to 15, 15 to 22. So basically what we have to understand is that for the first 2 months, we have to give them syrups, and we can go on to a full tablet when the child is about more than between 2 to 5 years. Next, please. Now, how to treat? Now, the treatment of PCP, please could you go back? So the treatment of PCP would essentially depend upon the severity. So like cotrimoxazole stays the mainstay. It is the mainstay. It is the fulcrum around which the treatment is given for PCP, whether mild to moderate or moderate to severe. The only thing that changes in mild to moderate and moderate to severe is the addition of steroids or possibly shifting cotrimoxazole to a IV preparation instead of an oral preparation. Now let us see what we do in a mild to moderate. A mild to moderate PCP would be one in which there is no hypoxemia or hypoxemia is only very mild. So in such cases, we would give them cotrimoxazole in 3 divided doses. And the actual dose is trimethorphan 15 to 20 milligram and sulfamethoxazole 75 to 100 milligram per kg per day divided in 3 divided doses. But the rule of thumb that makes it easier for all ART centers is according to the weight. This is for the adult. So if there is an adult of 30 kg, that person needs 3 tablets in a day. So you give 1 double strength cotrimoxazole tablet TDS. If the patient is 40 kg, then he needs 4. So you can make it 2 tablets in the morning, 2 tablets in the evening. 50 kg, 2 tablets morning, 1 in the afternoon, 2 in the evening. 60 kg is 2 tablet TDS. So that is the rule of the thumb for Septron DS to be given in patients who have active PCP and whom we have to treat. We have to treat them for 21 days. And if the patient cannot tolerate sulfur, then we can give Dapsone, or one option is Primaquine. Now, if the patient has hypoxemia, so that is moderate to severe. So in hypoxemia, what you would do is you would continue to give cotrimoxazole in the same dose. The dose of trimoxazole doesn't change, but you have an option of giving it IV. Practically, it is very difficult and very expensive to arrange a Septron injection IV, but it can be done because it is available. This is an injection which is available in India. So along with the IV injection or oral in the same dose, you would also have to start the patient on oral steroids. The choice would be prednisolone, and the best is to give it as early as possible. And another thing why we want to give steroids is that when we start treating patient of PCP, the first 72 hours are critical, because when we kill the fungus, when our co-trimoxazole kills the fungus, sometimes you can have a reaction to the dead protein parts of the fungus, and you can actually see worsening of PCP. So the time to start steroids is during the initial phase, and we should start it as early as possible and continue it for all the 21 days. Day 1 to 5, give 40 milligram per kg. Day 6 to 10, give 40 milligram BD. Days 6 to 10, give 40 milligram OD, and days 11 to 21, 20 milligram daily, and then stop. So basically start with 40 milligram BD and taper. Next, please. The total duration of treatment is 21 days. Next, please. And this is the chart. I think you will have to keep this chart for children, because it's not possible to memorize all the charts. Next, please. Now coming to bacterial pneumonias. Well, bacterial pneumonias or community acquired pneumonias are common in non-HIV positive patients also, but in HIV positive, we know all infections become more common. Next. And recurrent. So the most common, we have already had a talk of TB, PCP, and now we are on the pneumonia. The incidence of pneumonia increases by 6 times in untreated HIV patients. Next, please. The risk factors for pneumonia in people living with HIV is low CD4 count, especially below 100, lack of ART or intermittent use of ART, other things which can affect your lung health, that is tobacco, alcohol, and injection drug use, a disease with the immune suppression like chronic viral hepatitis, chronic obstructive pulmonary disease, malignancy, renal insufficiency, CHF. Please remember any condition, any other additional condition which brings down your protein level, like renal insufficiency. You don't have proteins in your body, you don't have immunity. You have a damaged lung like COPD, you are more prone to pneumonias. Congestive heart failure because of the pulmonary hypertension component is a very important cause of having pneumonias. Please remember that people with heart disease are at a higher risk of pneumonias. Underlying other pulmonary diseases like childhood bronchiectasis or chronic lung diseases. These are especially the risk factors for children living with HIV. Next, please. So in adults, you would see an acute illness. A bacterial infection is usually an acute illness, 3 to 5 days of symptoms, fevers with chills, chest pain, pleurisy, cough, which is usually a purulent sputum, dyspnea. There is tachycardia, fever. There could be other indicators of sepsis like hypotension and decreased arterial saturation. In children, again, it is fever, tachypnea, and chest indrawing. The danger signs for pneumonia in children are not able to drink or breastfeed, keep going on vomiting, convulsions, poor sensorium, lethargy, and stridor. And tachypnea would be defined as I had just told you about for PCP, which is the same way the tachypnea will be defined. Next, please. Classification of pneumonia in children. For children aged less than 5 years with cough and difficulty in breathing, cough and cold and no pneumonia, we only have to do home care. We have to tell the parent to take home care, give drugs, antibiotics for home, and that's all. If there is fast breathing and chest indrawing, and there is pneumonia, like if there's only cough and cold, that means only URI. That means upper respiratory tract, nothing to be done, home care. If the breathing is fast and chest is indrawing, then okay, the child has now got pneumonia. Please start the child on oral amoxicillin and home care. But if there are signs of serious illness, like the danger signs that we just saw, then we have to send up the patient for injectable antibiotics, supportive therapy, and basically admission. Next. Now, as I said, bacterial pneumonia is common in HIV negative also, but the problem with bacterial pneumonia in HIV is that it would be recurrent. A recurrent pneumonia would mean current episode plus one or more previous episodes in the past 6 months. And recurrences would be severe recurrent bacterial pneumonia, current episode plus one or more in the previous 6 months. For adults, it would be defined as a respiratory rate more than 30 and oxygen saturation less than 90. For children, it would be cough with fast breathing, chest and drawing, nasal flaring, wheezing, and grunting. Next, please. Diagnosis is microscopy. Send the sputum for microscopy. You get a gram stain done. Please do not forget the AFB. Always get a AFB and CBNAT done, even if it is a short history. We know in PLHIV, any cough, any duration can be TB. So when you are sending microscopy, please, for gram stain, please also send for CBNAT. Culture of common, you can send sputum cultures, an X-ray. A white cell count is very, very important. And as I said, AFB staining and TB cultures. Next. So how do you differentiate between PCP and bacterial pneumonia? One would be the CD4 count. Well, PCP will only be seen in low CD4 counts, which are less than 200. And as I said, CD4 can occur at any pneumonia. In PCP, they will almost always be a non-productive cough. And there might or might not be fever, and it will be a slow onset disease with increasing dyspnea. Well, pneumonia will be an acute illness, high fever, 3-4 days, purulent sputum. There would be focal lung signs. So when you put the stethoscope, you can hear creps on a particular segment. When you see an X-ray, you can see where the lung is affected. While in PCP, there might be nothing in the lung on auscultation, or there might be few inspiratory dry creps somewhere. Also, the WBC count is almost always elevated in pneumonias. And there is a neutrophilic predominance, like you will have about 90% pneumonia, 90% neutrophils, 88% neutrophils. Then you see a bacterial pneumonia, which is usually not present in PCP. The X-ray of PCP, again, I said, would be normal or diffuse ground glass, while there will be focal signs in a mnemonic X-ray. And pleural effusions are rare in PCP. There are more in pneumonias. So next. General considerations of management. Treatment duration should be 5 to 7 days. Patient should be afebrile for 48 to 72 hours and should be clinically stable before you discontinue the antibiotics. Longer duration of antibiotics is often required when there is a severe pneumonia or bacteremia is present, particularly if due to S. pneumonia or complicated Staph aureus infection. Switch from IV to oral therapy, and a switch should only be considered for patients who have at least showed some initial improvement with the IV drugs, can swallow, can tolerate oral medications, and have an intact GI function. That is, if they are not having continuous nausea, vomiting, diarrhea. So like they are able to actually tolerate the oral drugs. Next, please. What is the treatment? For non-severe cases, the preferred therapy is a beta-lactam. Beta-lactam are basically the penicillin group and the cephalosporins. So what we would give would be, the ideal thing would be amoxiclav with a combination of a macrolide, which would be azithromycin or clarithromycin. So amoxiclav with azithromycin is actually a very good and doable combination for bacterial pneumonia in the ART center. For children, we usually avoid clav, so it would be oral amoxiclav given twice a day. Alternatives could be that you do not want to use amoxiclav. Some people have a lot of diarrhea with amoxiclav, so you can use a cephalosporin. Cephalosporins also cause diarrhea to a certain extent, but not that much. And you can give drugs like ceftriaxone are very easily tolerated. Drugs like cefpodoxime, they cause a little diarrhea, but ceftriaxone is very easily tolerated. And you can also try giving a respiratory fluoroquinolone, though we try to avoid fluoroquinolones in India because of its use in tuberculosis and the combined response that you might get in tuberculosis because of use of a fluoroquinolone. In children, the alternative would be cotrimoxazole and azithromycin. Next, please. For patients who are in the hospital with non-severe cases, we would like to give the same drugs through an IV. So we would like to give an IV beta-lactam, which would be a ceftriaxone, a ciprofloxacin, or IV augmentin. We could also give an IV respiratory fluoroquinolone like levofloxacin. And again, we have to add azithromycin. For children, it would be an ampicillin injection or benzyl penicillin injection along with gentamicin. The alternate therapy to a beta-lactam plus doxycycline would be IV penicillin itself, especially for confirmed pneumococcal pneumonias. Next, please. Now coming to patients with severe pneumonia. See, the essential treatment doesn't change for severe pneumonia also. It still remains an IV beta-lactam plus an IV azithromycin, or you can use an IV beta-lactam plus an IV fluoroquinolone. So you can either use a macrolide or a fluoroquinolone, and the preferred beta-lactam would be a ceftriaxone, a cefotaxime, or augmentin. So it actually really doesn't change. Alternatives would again be a carbamazepine. Carbamazepine is a meropenem, plus a IV respiratory fluoroquinolone. When you give a meropenem, then you don't have to use an azithromycin. Whatever you add on should be a fluoroquinolone. Next, please. Now, patients who are at risk of Pseudomonas pneumonias are usually seen in immune deficient people, and sometimes it's a hospital-acquired pneumonia also. So you would have to use an IV anti-pneumococcal beta-lactam plus a respiratory fluoroquinolone. And what would be the preferred beta-lactam for Pseudomonas? It would be piperacillin tazobactam, or cefepime, or imipenem, or meropenem. Alternative therapy would be an IV anti-pneumococcal anti-Pseudomonas beta-lactam plus an IV aminoglycoside. So you can give an instead of a levofloxacin, you can give a IV aminoglycoside or an anti-pneumococcal fluoroquinolone. So it is basically essentially the same. You have to keep on actually rotating the same set of drugs, which is a beta-lactam, which is a macrolide, which is a respiratory fluoroquinolone. And as an alternative, you can actually also use a imipenem, meropenem. Next, please. Now coming to MAC. Next. MAC is Mycobacterium avium complex. These are Mycobacterium which are other than tuberculosis. There are several Mycobacterium other than tuberculosis, but the commonest among these Mycobacteria is Mycobacterium avium complex. This is something that we see in HIV disease, but it is more commonly seen in places where Mycobacterium tuberculosis is not endemic. In places where Mycobacterium tuberculosis is endemic, like India, we rarely see MAC. But yes, in the West, in Australia, in USA, in Europe, HIV patients are known to have more MAC than MTB. MAC is again a ubiquitous bacteria. You can find these bacteria in the water, in the soil, in the air, and the mode of transmission can be through inhalation, injection, or inoculation of these bacteria through the GI tract. It will occur with people living with HIV, CD4 is below 75 or 50. Patient presents, in this case also, usually there's a long history of a patient being sick, being wrongly diagnosed, getting a treatment of ATT or getting antibiotics, not doing well, coming back to you. But it is a very, 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 very rare disease. Even in a TB hospital, we have seen only 1 or 2 cases of MAC with PLHIV in these past all these years. So patient may present with fever, night sweats, chills, weight loss, and there would be enlargement of liver, spleen, and lymph node. Please understand, MAC would be a disseminated disease. A confirmed diagnosis of disseminated MAC is based on these signs and symptoms, coupled with isolation of MAC from culture of blood, lymph node, or bone marrow, if we do not have any other site, and other normally sterile tissue or body fluids. Routine prophylaxis for MAC is presently not being done in India. Next. How do you manage? I would really say management of MAC is not in the purview of an ART center. If for some reason you are suspecting MAC, there is somebody with a intrathoracic lymphadenopathy or disseminated lymphadenopathy with some hepatosplenomegaly who has not responded to usual treatment, who is probably CBNAT positive but culture negative, or something like that, that makes you suspect that, okay, this patient can have MAC, his CD4 is very less, then I would sincerely request you to send that patient to a TB specialist or a respiratory physician or internal medicine OPD for correct diagnosis, because diagnosis of MAC requires isolation of the organism from a sterile cavity or in the histopath or in a tissue sample. So which we cannot usually do in an ART center, but just to complete the list, I would say the treatment depends upon clarithromycin, ethambutol, and rifabutin. And the criteria for discontinuing is that we have to give at least 12 months of therapy, and the CD4 should be more than 300, 6 months apart. Next. Now coming to Talaromycosis, which was previously known as pencillosis. Next, please. Now, this is a fungus. It is a dimorphic fungus, and it was earlier known as Penicillium marfani. Now it has been renamed as Talaromycosis. It is seen by and large in Southeast Asian countries only. It is not seen in the West or in Australian countries. And in India, it is mostly in the Northeast India where it is present in the soil. It causes a subacute illness, fever, weight loss, hepatosplenomegaly, and lymphadenopathy with respiratory and GI abnormalities. The very typical thing of Penicillosis marfani is that it will be accompanied with skin lesions. And these are such typical skin lesions. They are central necrotic papules with umbilication appearing on the face, trunk, and extremities. Next, please. These pictures are very, very self-explanatory, and these eruptions are present for quite some time. Like, these are not like chicken pox or measles or some other exanthematous fever, which would just come and go in 14 days. They are there for a long time. And if you will see, all these papules, they have a central umbilication. There is centrally, they are depressed. Next, please. So pulmonary symptoms are cough, shortness of breath, which would be accompanied by diarrhea, abdominal pain, hepatosplenomegaly, abdominal distension, pain, and lymph nodes in the abdomen. CNS can be affected with meningoencephalitis, and there can be anemia, thrombocytopenia, and raised liver enzymes. Next. So one would be a presumptive diagnosis, which would depend upon the CD4 of the patient and also on the skin rash. And microscopic examination of the scraping of the skin, or from the lymph node aspirate, or from bone marrow aspirate, or tissue sections, where you can see the fungus in Giemsa, Wright, or Gomori methamin silver stain samples. Definitive diagnosis would be demonstration of the fungus in a histopath biopsy specimen. Antigen detection and PCR methods are still under the research modality. Next. Shweta, can you hear me? There is some complaint about the sound.
Ma'am, the sound is clear.
Okay. Sound is clear, ma'am.
So preferred therapy is amphotericin B. If the patient can afford or the system can provide him liposomal amphotericin B, well and good. If the patient cannot afford it or the system cannot provide it, then we can go with the regular amphotericin B also, which is given in the dose of 0.6 milligram per kg per day IV for 2 weeks. After giving for 2 weeks, we shift the patient to itraconazole 200 milligram daily for 10 weeks, followed by a secondary prophylaxis with itraconazole 200 milligram daily till the CD4 is more than 200 on 2 occasions 6 months apart. Next, please. Next. So this was about Talaromycosis or Penicillium marfani. Now in very brief, I would cover other pulmonary manifestations of other pathogens next. Now this is a little content heavy, and I really don't want to go into the details. Histoplasma is a fungus, and you would again have the similar symptoms like cough, chest pain, dyspnea. The reason we are talking about this here is because in HIV it can be a disseminated infection, and the treatment and how would you detect it? It can be cultured from the blood through fungal cultures, and you can also have it from bone marrow, from respiratory secretions. You can culture it. And detection of histoplasma antigen in blood or urine is a sensitive method for rapid diagnosis. So there's a rapid diagnosis for histoplasma also, and treatment would again consist of amphotericin. Next, please. Nocardiasis again Similar, but this nocardiasis usually has a chronicity. So there will be a chronic cough, chest pain, dyspnea, and rarely skin can be involved. It is very often used to be seen in in renal dialysis patients. This used to be common. And X-ray would have pleural effusions, cavitations, radicular-nodular, which would actually look like TB. So the only way that you could actually do is that you take a bronchial washing or a very good sputum sample, and it is isolated, and you isolate nocardia from it. But isolating nocardia is not easy because it takes weeks to grow, and you have to have a degree of suspicion that, okay, I have to put the nocardia test also. So again, the treatment for this would be cotrimoxazole and amikacin. Next, please. Aspergillosis is common in HIV negative also. There is an allergic bronchopulmonary aspergillosis, which is one type of aspergillosis. The other would be Aspergillus mycetoma, or a fungal ball in an old dead cavity. And the third can be invasive aspergillosis, that is disseminated. This occurs in PLHIV and presents with fevers and pulmonary consolidation and hematogenous spread. Chest radiograph would include thick walled cavities, most commonly in upper lobes, and culture of organism is possible from the sample taken from a lung. For this, again, we should treat with liposomal amphotericin B. The regular amphotericin B is not very effective in aspergillosis, and you can also use voriconazole. Next. So this is mostly about the usual months. When if we talk of respiratory OIs, how can we not talk about COVID-19? COVID-19, I don't think there is anything much left to discuss. We are all bubbling with information about COVID-19. We know what is mild, what is moderate, what is severe, when and when to start steroids, when to do budesonide nebulizations, to give Monter LC, the usual dose we know, the usual azithromycin. So this was the earlier recommendations that had come out in April to July 2021. But now with the Omicron variant and the Delta Omicron variant, usually it is said that these patients require no treatment other than rest and lot of fluids and paracetamol for bringing down fever. Occasionally, some azithromycin might have to be given to prevent secondary infection. And in case of increasing dyspnea, one has to report to a hospital as soon as possible. So today, this is the recommendation for COVID-19. It has changed from what it was earlier with the changing variant. Next, please. In COVID-19, upper respiratory tract symptoms would be mild disease with no shortness of breath or hypoxia, dyspnea, evidence of lower respiratory disease with SpO2s between 90 and 93 on room air, and respiratory rate of less than 24 would be moderate, and severe would be a respiratory rate of more than 24, SpO2 of less than 90 on room air, and is an indication for hospitalization. Next. Risk factors for mortality and severity of disease in PLHIV would be a PLHIV with COVID with age more than 60 years, having a pre-existing cardiovascular disease, having diabetes, having chronic lung, kidney, or liver disease, a cerebrovascular disease, or obesity. Next. So this was all, I think, so this was all, we know the treatment with steroids, without steroids, when to give steroids, when to refer for hospitalization. And I think this was all about respiratory infections. If there is any question, I think I and Dr. Reshu would be happy to take them.
Thank you, ma'am. We had a question in the chat box. Reshu ma'am has already answered it.
Okay, thanks.
Kiran, can we please unmute the participants now?
Done, ma'am.
Participants can now unmute their mic and ask questions, or they can even type in the chat box. Please feel free to unmute your mic and ask questions.
Hello, madam.
Anji.
Madam, sometimes we get cases of Kala azar or cryptococcal or penicilliosis. Amphotericin B was not available, madam.
Pardon? Pardon, ma'am?
Ma'am, can you please again unmute?
Hello.
Yeah, we can hear you.
What was not available, ma'am?
Amphotericin B.
I know, ma'am, amphotericin B is one of the essential drugs for opportunistic infections. And Dr. Reshu, please can you tell us what is the current status? Like, does the SAT have to procure it, or does the hospital have to procure it?
So if it is available in the hospitals, you should be you should speak to your superintendents and nodal officers to get the drug. And if it is not available in the hospital, then you should reach out to the state, and they can allow you to procure this drug through the funds available for OI drugs.
So, ma'am, the answer for that would be many hospitals, multi-speciality hospitals have amphotericin B as a part of their formulary. So you can use the same drug from your hospital for them. If your hospital's formulary doesn't have amphotericin B, then please ask your state AIDS control organization who have a OI fund.
Okay, ma'am. Thank you, ma'am. And in the pneumonias, we commonly see staphylococcal and the gram-negative pneumonias, madam, when we do gram staining.
So for gram-negative, what we would suggest is to add, like we said, that give one beta-lactam and one macrolide.
We need
and a macrolide.
हाँ मैडम.
है ना, so macrolide को add करोगे और अगर आप third generation use करोगे तो gram negative will also be taken care of.
मैडम नहीं उसको लिए निपेनम मेरोपेनम का जरूरत पड़ेगा शायद ऐसे.
Not all cases.
बताया हाँ already.
Not all cases. Only if they are resistant to other drugs, then you have to go on to meropenem. Meropenem is the oral version.
हाँ मैडम. I added cefodoxime and amoxiclav. Sometimes they've responded.
Ma'am, amoxiclav will work against gram negative. Amoxiclav is a drug which acts against gram positive, gram negative, and anaerobes also.
And
so that is the beauty of amoxiclav. With the cephalosporins, there is no coverage for anaerobes.
हाँ मैडम. हाँ, but cefodoxime is active in both gram negative and gram positive.
Yes, that is why the preferred is cefotaxime. Cefotaxime, ceftriaxone, these have a more wide gram negative coverage also. And once you pair them with a respiratory fluoroquinolone or a zithromycin, that is a very good coverage actually.
We have cefotaxime, ceftriaxone, but higher this thing like cefepime, ceftazidime, clindamycin IV, and like that we don't have that supply, madam.
Ma'am, but uske liye, if you have to go to all that level now, so that means the patient needs to be admitted. Or somebody who is coming to the ART center and jisko aap OPD basis pe usme amoxiclav and azithromycin ya amoxiclav and levofloxacin is a good option.
No, what I was saying, if we need higher antibiotics, then what we should do? That was my question.
So the question is, how do you do it for people who do not have HIV? Like there must be people who need that, like they would be hospitalized in your hospital.
Yeah, yes.
So from the same way it is arranged for people without HIV, it would have to be given to people with HIV through the hospital system of admission.
Okay, madam. Thank you.
See, for all practical purposes, all PLHIV are part of the, I mean, they are getting care from the hospital. So the way like non-PLHIV are treated, PLHIV should also be treated in the similar manner.
Yes, madam. But sometimes we don't have higher antibiotics and some drugs like you said you get fluid from state, no, madam. That's what.
Yeah, that you can speak to your state, like wherever you have specific requirements that you can communicate with your state.
Okay, madam. Thank you.
Any more questions from the participants? Participants can unmute their mic and ask questions. Ma'am, I don't think there are any more questions.
Okay, so then let's move on to the
post-test.
Can I request you to end the session, Shrita?
Sorry, ma'am.
आप सेशन एंड कर देंगे? कैन आई रिक्वेस्ट यू टू
जी जी जी, थैंक यू सो मच मैम फॉर योर टाइम, एंड थैंक यू रेशु मैम.
Thank you,
Thank
Dr. Reshu, for your support. Thank you, Dr. Puri, for your support. Thank you so much.
Yeah,
Thank you
ma'am.
so much. Thanks everyone for participation.
Kiran sir, can we quickly run the post test, please? The post test is now visible on your screen. There are 3 questions in all. Please scroll through the questions and answer all the 3 questions.
Ma'am, this is not visible.
Participants are requested to please attempt the post test. Kiran sir, we can end the post test now. Here are the answers to the post test. Which of the following are the manifestations of PCP? Mark all that applies. The answers are: in children, sudden onset of fever, although a fever may not always be present. And in adults, chest X-ray characteristically shows a ground glass appearance that is more pronounced in the lower lung zones. Second question, which of the following statements regarding prophylaxis of PCP in PLHIV is not true? The answer is primary prophylaxis is indicated when CD4 is less than 200 cells per millimeter. Third question, which of the following is true regarding differentiating features between PCP and bacterial pneumonia? The answer is: on X-ray, PCP is bilateral in occurrence, while pneumonia can be unilateral, lobar, or segmental. Kiran sir, can we have the feedback poll, please? The feedback questions are now visible on your screen. There are 4 questions in all. Please scroll through the questions and answer all the 4 questions. Thank you, Puri sir, for joining us for the opening remarks. Thank you to Upasna ma'am and Reshu ma'am for facilitating this session. Thank you to all the participants for patient listening. Kiran sir, we can end the e-poll now. Thank you. We'll conclude the session now.